A very good morning to you all students. Hope all of you are doing well. On 4th, we studied and we oriented you towards various programs that are available within the campus and various institutes that are present within our campus. We also oriented you about our Pravra Rural Hospital. Now today what we are going to do is we are going to look beyond the campus into the community. Our institute does a lot of community work, and your medical education will also not be limited to just a specialty hospital, but also would include public health and community services. And that is why today we are going to cover various aspects of community oriented medical education with special reference to activities that are being carried out at PIMS. So, community oriented medical education is an integral part of your curriculum, and we take it very seriously. So basically the first question that you might ask is, what is community oriented medical education? Community oriented medical education is a collection of educational, healthcare and research activities based on needs of the community, so that it may lead to provision, maintenance and improvement of health in individuals. So basically what we do is we ask the community what sort of healthcare they want, what are their needs, and then cater to their needs. So to do this, and any practitioner who is not able to cater to the needs of community doesn't succeed. Now, why do we need community-based medical education? So we found that graduates generally are not prepared to provide primary healthcare in the community. So you have all led a very sheltered life. You might not have interacted with a wide variety of people in the community, and just knowing the theoretical aspects of medicine is not enough. As long as you are not able to interact very well with your patients, with different members of community, with people from different backgrounds, you will never succeed as a doctor. So the community oriented medical education can help produce health oriented professionals who have the skill sets to be able to provide health promotion, disease prevention, curing of the disease and rehabilitation. So you must note that curing the disease is a very small part of your education, right? Other things are equally important. Now, how is community oriented medical education different from other kinds of education? So in a clinical medical setup, the patient comes to the doctor, whereas in community medicine, the doctor goes to the patient. Clinical medicine focuses on individuals, whereas community medicine focuses on the entire community as a whole. A clinician concentrates on finding cause of the disease, whereas a community physician would try to find the cause of the causes. What do you mean by cause of the causes? So for example, you would say that drinking alcohol leads to liver disease, right? So a doctor, a clinician, a general physician would say that drinking alcohol is causing your liver disease, whereas a community medicine professional would try and find out why the patient is drinking alcohol and try to remedy that. Okay? Curing the disease. So clinical medicine concentrates on curing the disease, getting rid of the signs and symptoms, whereas a community health professional would concentrate on ensuring health. The clinical diagnosis is usually based on lab finding, radiological findings that we saw last time we discussed the hospital setup. Whereas in a community diagnosis, we take data about the clinico-social factors in the community and then reach a holistic conclusion which determines the risk factors, the barriers, the pros and cons of living in that community, and it gives us an idea about what action needs to be taken at the community level, at the family level, in order to get rid of the disease as a whole. With community oriented strategy, we find that a small change in behavior of a large number of people can lead to drastic improvement in health of the entire community. For example, even if 10% of people in community quit smoking, that would significantly reduce the number of patients suffering from lung cancer. So the first thing you should know is when will we teach you and what will we teach you. So you will find that community medicine stays with you from first year to the third year, right? So for nearly 4 years we will be teaching you, and we will also be teaching you in internship. So हमसे पीछा छुड़ने वाला नहीं है, ठीक है? The first year students, what we teach is how to take socio-demographic profile of the family. So you will actually go on a field visit, you will interact with people in their homes, you will take details from those families, you will inquire about their dietary history, their nutritional habits, and you will counsel them regarding proper nutrition. So this is what will be covered in your first year. In second year, what we will do is we will teach you about environmental health. So different environmental factors, different social habits, customs, addictions, economic situation, and its impact on health of the community. In third year, you will document the vital events, you will conduct preventive checkups of all family members of the families that are allotted to you, and you will present a family study survey as a part of your final evaluation. How do we teach this? We conduct community postings, जिसमें we'll take some theory lectures, we'll take some visits, we will take you to at least 5 families that you will have to follow up from your first year to your third year. Then we will also post you at Urban Health Training Center, which is at Prauranagar, and Rural Health Training Center, which is at Rahata. There will also be visits like Anganwadi, Sub-Center, PHC, CHC, District Hospital, and various program offices like District Tuberculosis Office, District Malaria Office, etc. These topics will be covered in detail in the next presentation by Dr. Rutuja. The old age home, schools for differently abled, factory visits, dairy visits, visits to water purification plant will also be conducted for you. I will take this opportunity to let you know that we have recently inaugurated a state-of-art water purification plant in our campus itself, which has the capacity to purify 50 lakh liters of water at a time. Why do we do it? We want to educate you, we want to empower you, and we want to teach you how to act properly. So the education aims to integrate the preventive, promotive, curative and rehabilitative aspects of health services in the community. You must learn to appreciate the social, psychological, cultural, economic, environmental and behavioral factors that learn about signs and symptoms of the disease. Empowering students with knowledge, skills, positive attitude, which is the most important, to work within the communities, and to empower them to conduct behavior change communication, which is one of the most difficult things to achieve, right? And you must direct the community, you must become community leaders and direct the community towards positive health. You must learn how to act, not just to read, imbibe and understand. You must be in a habit to act by conducting research, by applying appropriate technologies, by designing strategies to prevent and control diseases as per the needs of the community. You must be able to apply these principles of epidemiology and statistics that we teach you and translate them into rational decisions. So basically what you need to do is you need to look at the data, understand the problem and provide solutions to common men. You will be given this family study and survey journal that we have designed. Our institute is one of the few institutes which has revamped the journal to suit the needs of community-based medical education, and a new journal will be provided to you this year. Now let us look very shortly about the family health survey that you will be conducting so that you get an idea. So first thing, how do we do it? We take you on a field trip. So you will enjoy it a lot. So your entire batch will go on a field trip. You will have a spot map designed specifically for your field practice area. A separate field practice area is allotted for each of the batch, and we have a lot of community outposts that we manage. We will be using new technologies like geographical information system, GPS, and you will chart out the area before you actually go to that area. So you will know about the geographical features of the area way before you reach the area. You will also have a village schedule with you which will detail the information about that particular field area. For example, name, population, sex ratio, number of children, various amenities like water, lighting, agricultural products, like transportation facilities, hospitals, climate that are present in that area. You will also know about the health facilities that are available in that area, so you can try and link the population with the health facility. For example, if one of your family member has got diabetes and he has to spend a lot of money getting treatment from a private practitioner, you can refer him to the nearest public health facility where he will get medicines free of charge. So you, as a student, you may not be able to treat the diabetes, but you can certainly direct the patient to the proper center so that he can save a lot of money and get better quality of treatment. What will you do? You will be allotted 5 families. You will go and you will code each of the households. You will interact with the people, take data. You will fill some pro formas that we give you. Then you will enter that data in Excel, and we will teach you how to analyze that data and reach the proper conclusions. Right? Then you will present that data in a proper manner. You will talk about family types, family size, age and sex distribution, the distribution according to religion, education, occupation. So just looking at these parameters, you will get a general idea about what kind of life your community, patients in the community might be leading, and your solutions will be specific for them, can be tailored for them, right? So for example, a driver may not be able to eat at same time every day. He might not get sleep properly, and therefore just counseling him to eat properly and sleep properly may not help. You might have to provide him with some solution that works for him. Socioeconomic status, we will take all sorts of parameters, family planning services, unmet needs. Pregnant women and children will take information about them, their immunization status. We would also look at morbidity profile, that is what are the common diseases that are present in the community. We will look at addiction, what are the areas where people have higher proportion of addictions, what are the reasons for addiction, what sort of addictions do women have, right? So you will get a better understanding of all the risk factors that cause disease. Environmental factors, sanitation, housing, overcrowding, animals, animal shelters, water supply, storage and disinfection methods, sanitation, as we have seen, environmental risk factors like vector breeding sites, and what are the various practices that these people follow, what kind of lifestyle do they lead, do they use gas cylinders, do they use chulhas, what are the various businesses that they indulge in, what are the schooling facilities available to their children, what are the self-help groups that are present within the communities. So basically you will go in the community, you will interact with community, you will gain their trust and become a part of that community, so that you will be able to advise them properly regarding improvement of their health and well-being. And finally, we will also be comparing various communities and try to compare and contrast and find out the difference between their lifestyles and difference between the pattern of diseases, and so that you will get an in-depth understanding of what kind of lifestyle factors, what kind of environmental factors, what kind of host and agent factors lead to various diseases. So you will not be just a bookworm doctor, you will be a community oriented doctor. You will have a lot of confidence to go and talk to patients, to treat them, to advise them. You will know what to say, what not to say, right? And you will be able to suggest action, take initiative, reach community diagnosis. Now what is a community diagnosis? Community diagnosis is basically a description of health of citizens and factors which influence their health. It identifies problems, proposes areas for improvement and stimulates action on part of the society. So this is what you will be doing. You will be informing them through rallies, through various role plays, skits, pamphlets, right? You will be educating the people and you will be communicating effectively with them. So you must inform, educate and communicate effectively with the people, and our institute will provide you the best possible education in this regard. You can also conduct community-based research as an undergraduate student, because we have a very robust research program for undergraduates, and that would help you in your career. Whether you stay in India or you go abroad, you will benefit a lot from whatever research you do as an undergraduate. So thank you very much for listening. Now I would like to call upon my colleague Dr. Rutuja, who is an associate professor in our department of community medicine, and she would be talking about a very interesting topic, that is Anganwadis.
Hello and good morning students. Myself Dr. Rutuja, Associate Professor, Community Medicine Department. Today we are going to see Anganwadi. Today we will be seeing the working condition, objectives and theoretical part of Anganwadi. Once you come in the campus, we will go for the visit to various Anganwadis. So everyone knows about Anganwadi. What do you mean by Angan? Each and every house has an Angan, that is the courtyard. So Anganwadi. The word Anganwadi means courtyard shelter in Indian language. See, here you can see the Anganwadi worker taking non-formal education for small children. So who are benefited basically by Anganwadi? Mainly the children between 0 to 6 years of age group. What are the basic things which are taken in Anganwadi? First one is the nutritional factor. Second is the non-formal education. Third is the growth charts, that is monitoring the growth of the child. So Anganwadi started in 1975 as a part of ICDS. So what do you mean by ICDS? It is a integrated child developmental services. So all the services which are made available by the government for the children are integrated under this program, and Anganwadi is a part of that. So Anganwadi is a government sponsored child care and mother care center in India. So it benefits the children between 0 to 6 years as well as the expected mothers, that is pregnant ladies and lactating mothers, adults and girls, and the women in reproductive age group, that is between 15 to 45 years of age. What was the main objective behind starting an Anganwadi? Was to combat the child hunger and malnutrition. The objectives of Anganwadi are to improve the nutritional and health status of children in the age group of 0 to 6 years, to lay the foundation for proper psychological, physical and social development of the child, to reduce the incidence of mortality, morbidity, malnutrition and school dropouts. Giving meals in Anganwadi was the basic for calling the children to the Anganwadi. So, as they are giving meals, the school dropouts have decreased a lot. To sum up, the objectives are doing regular health checkups, immunization, that is vaccination of the children, giving health education and non-formal preschool education, and giving supplementary nutrition. The beneficiaries are children between 0 to 6 years age group, expectant and nursing mothers, that is pregnant and lactating mothers, adults and girls, and other women in reproductive age group, that is between 15 to 45 years. So under ICDS, that is Integrated Child Developmental Scheme, one trained person is allotted for a population of 1000. Why this person is there? To bridge the gap between the common public and the hospitals. That is, this person will bridge the gap between the person and the organized healthcare, and to focus on the health and educational needs of children aged 0 to 6 years. And this person is called as Anganwadi worker. So they provide outreach services to poor families in need of immunization, healthy food, clean water, clean toilets, and a learning environment for infants, toddlers, and preschoolers. They also provide similar services for expectant and nursing mothers. According to the government figures, Anganwadis reach about 58 million children and 10 million pregnant and lactating women. Now we will see in detail the structure of Anganwadi working. Who people are there, how they work in details. The Anganwadi system is mainly managed by Anganwadi worker. She is a health worker chosen from the community and given 4 months training in health, nutrition and child care. It is compulsory for the Anganwadi worker to be one from the community where she stays. She is in charge of Anganwadi, which covers a population of 1000. So for per 1000 population there will be one Anganwadi, and in that there will be one Anganwadi worker. Along with that there will be one assistant who will be helping the Anganwadi worker to do the services. 20 to 25 Anganwadi workers are supervised by a supervisor, and that supervisor is called as Mukhya Sevika. 4 Mukhya Sevikas are headed by a CDPO, that is Child Development Project Officer. There are an estimated 1 million Anganwadi centers employing 1.8 million mostly female workers and helpers across the country. Then what is the role of Anganwadi worker? We have seen the structure. Now role of Anganwadi worker. She teaches mothers on health and nutrition. She coordinates with PHC. PHC is Primary Health Center staff for the health checkup, immunization and referral of suffering child. So from the rural area or from the population, the public or the common person will go to the Anganwadi worker first if the baby is not feeling well, and she will take to the primary health center. Or she has all the data, she will do surveys, she will be knowing who the lactating mothers are, who the pregnant females are, how many children are there below 6 years of age group, who are lack for the immunization, who are due for immunization. She will be having all the details, and accordingly, according to the dates and all, she will be taking the family or the child for immunization. If the baby is not feeling well, she will take the baby to the hospital. She provides treatment of minor illnesses. She carries out a quick sample survey of the area and families to find out the total beneficiaries. So beneficiaries are like children between 0 to 6 years, lactating mothers, pregnant females, adults and girls. So she will be having the detail of all this. Anganwadi worker maintains the growth chart of every child. So in Anganwadi, each monthly at a specific date, supposedly it might be 10th of a month, so on each 10th of the month, the Anganwadi worker will be taking height and weight of the child, and accordingly she will be maintaining it or jotting it down on a growth chart. I will show you the growth chart also. So she will take the weight of the child under the age of 3 years per month. Children over the age of 3 years are assessed with an upper mid-arm circumference. So she will be taking mid-arm circumference each monthly. She organizes non-formal education for children of 3 to 6 years age group. So in Anganwadi, the child above 3 years goes to Anganwadi for non-formal education, and the child between 0 to 3 years, the care is taken at home. So the three broad spectrum things which Anganwadi carries out is nutrition, growth, monitoring and non-formal education. We will see this in details. So nutrition part, the supplementary feed in Anganwadi can only provide a third of the child's requirement. So please let the parents know that if they are sending the child to Anganwadi, that doesn't mean that whole nutritional part is taken under by Anganwadi. Only 1/3 of his diet can be carried out in Anganwadi, rest everything has to be done at home. But the Anganwadi feeds help to attract the children and parents. So in rural area, you all know that the people will go in agricultural fields for work. So in morning hours, it is very difficult for the female or for the mother to take care of the baby. So it indirectly helps her for the nutritional factor, as well as she can spend her time in the farms and the child can go to Anganwadi. So there is a specific schedule which is given to all the Anganwadis. It depends mainly on what food pattern the area has, but usually it is all over same for India. Breakfast is served when the Anganwadi starts. So when the child goes to Anganwadi, firstly they serve the breakfast, and once the baby leaves out, that is usually the Anganwadi is from 9 to 12 o'clock. So 9 o'clock the baby will go or the child will go, and then he will have his breakfast, and when he will leave, that is around 12:30, he will have his meal, that is lunch. So breakfast is served when the Anganwadi starts, and there is a meal before Anganwadi center closes in the afternoon. So for breakfast they serve cooked legumes, that is usar, podrich or dalia, broken wheat, lapsi we say. The meal has either khichdi, that is rice and dal, or similar items. Every district has almost similar time schedule, and it is displayed on the Anganwadi center wall. So this is a pattern you can see कि from Somwar to Gurwar, that is from Monday to Thursday, they have shown कि where that is 9:30 and 11:30. At 9:30 they will be given the breakfast, and 11:30 lunch will be given. So everything in details they have given कि how much wheat they will take, how much oil they will take, sugar how much they will take, and in detail the calorific value of the diet whatever they are giving to the child. Why this is important? Because in areas there will be malnutrition. So if the baby is having malnutrition or is underweight, in this situation this calorific intake will tell us ki how much increased calories we have to give to the baby. If the baby is obese, then we can decrease it a little. So calories are very important. Usually the Anganwadi worker herself used to cook first, but there are so many things to do. So like nutrition part, growth chart part, non-formal education. So one assistant is also given to her who will help her to cook, to take other activities. So supplementary feed and Anganwadi center assistant. Till some time ago, it was Anganwadi center who cooked the meals. For this, she got some resources and provisions. Even now, the assistant prepares the meals where there are no self-help groups. If assistant is not there, then the worker herself has to do it. Many Anganwadi centers have a small kitchen for this purpose. So here you can see the kitchen. There is a chulha. So like this, every Anganwadi center has a small room that is a kitchen. There may be LPG gas, chulhas, or there may be kerosene or rockel stoves. So a chulha or a kerosene stove is used if there is no gas. But there are some limitations about what an assistant can cook. So if the assistant is from the same area, then she can help around a lot. So behind all this, the government gives 4.92 rupees, that is 5 rupees per child spent. This includes grains, dal, salt and spices and oil. This all is provided by the government. In tribal area, 1 extra rupees is given. That is, in tribal area, per child is 6 rupees. If the child is severely malnourished, then again 1 more, that is additional provision of rupees 1 is available, so that the child will be given more calorific diet. The assistants, those who help, gets 60 paisa per child per day, including firewood and kerosene. So some public distributory systems are also there which will provide the grains. So here you can see the grain or the ration which the Anganwadi gets. So in some districts, Anganwadi centers have managed to get food grains like dal, oil, sugar, rockle, etc. from public distributory systems. In some districts, these items are purchased from other shops. Sometimes in some places it was seen that government was not able to distribute it properly, so the Anganwadi centers themselves have gone to the Sarpanch, and then the Sarpanch has arranged that from each house a small amount, a very small amount, if given to the Anganwadi, it will give a good amount for the children. But the Anganwadi centers or self-help centers cannot afford this. So instead of buying it, what they did, they told to each and every household to whatever wheat or grains they can give. So just मुट्ठी भर पण दिलं तरी चालेल ऐसे बोल के they have collected a lot amount of grains. Possibly the food security schemes will solve this problem. Then self-help groups and take-home ration. As I have told you that children above 3 years will come to the Anganwadi. So what about the children between 0 to 3 years or the lactating and the pregnant females? To this group we will give take-home ration. It is similar like Cerelac. We just have to pour it in hot water or boil it, and then we can directly give it to the child. So usually it is between 6 months to 36 months. Why after 6 months, not between 0 to 6 months? Because the child or the baby is exclusively breastfed till 6 months. So there is no need of giving anything extra other than breast milk. So to these children above 6 months to 36 months, we will give take-home ration. And after 36 months, that is after 3 years, the child himself will come to the Anganwadi and get the nutrition in Anganwadi. So take-home ration, as per Supreme Court decision and government order, only self-help groups should prepare the take-home ration. The provisions for take-home ration is similarly 4.92 per child. Okay. So here you can see the packets. These are similar like Cerelac. You just have to pour the hot water in it. As I have told you before that it is for the children who are under 3 years, that is between 6 months to 36 months, and it is home use packets. THR packets are also given for severely malnourished child. If the child is above 3 years but the child is severely malnourished, then to these children we will give take-home ration so that the child will have food in the Anganwadi as well as at home. THR comes in 3 packs, that is 1 kg packs are there, Shira, Upma and Sattu. Pregnant and nursing mothers also get take-home ration. So see, here you can see the packets. These are 1 kg packets. It is expected that a small portion of the take home ration from the pack is mixed in hot water and or cooked fed to the child. Mothers are expected to eat their own take home ration provided from the Anganwadi center. So don't distribute it in the family. If the mother is expecting, that is she is pregnant or lactating, she should have her own THR. So first part we have completed, that is the nutritional part, that is supplementary feeds which are given by Anganwadi. Second part is the growth chart part. So in this, as I have told you, that each monthly the Anganwadi worker will be taking the weight of the child and then maintaining a chart. I will show you that chart. So growth chart is also called as road to health chart. Growth charts are used to compare your child's height, weight and head size against children of the same age. It provides an early warning for malnutrition. So see here, you can see the growth charts. This is for girls and this is for boys. Pink is for girls and blue is for boys. There is a little percentile difference between girls and boys. So there are two different gender wise. Here you can see the green band, yellow band and the red band. So all the time the weight of the baby should be in this green band. This is called as road to health. Okay. So each monthly, here you can see on y-axis the age of the baby is given monthly and this is the weight of the baby in kgs. So you have to jot it down, like supposedly if the baby is of 2 months and the weight of the baby is 5 kgs, so the point will come here. Okay. Similarly for each month you have to maintain. So if the weight is in the green zone, means the baby is healthy, no need of taking any tension. If the baby goes in yellow zone, means it is mildly malnourished, we can just increase a little bit of calories and maintain the weight again. But if the baby is in this red zone, that is the baby is severely malnourished and we have to take care. For this, the Anganwadi worker will give extra calories, even will show to the physician what are the main factors which are leading for this. So here you can see if the chart goes in this way, that is normal. If it is a flat, then we have to increase the calories a little, but if it is going downwards or it is declining, then special precaution should be taken. In growth chart, some basic things like how to treat for home treatment for acute respiratory illnesses, fever and diarrhea is given. Okay. So this is mainly maintained by Anganwadi worker and it is kept in Anganwadi center only, and each monthly the mother will come with the baby and we have to take the weight till 3 years. Okay, this is for girls and this is for boys. Then comes non-formal education. What do you mean by non-formal education? That is just teaching the poems, colors 1 to 10, ABCD. This is done here. Okay. Basically they are taught the toilet training, sitting together and eating, hand washing practices. This is taught in non-formal education. So see, you can see here, this is Anganwadi worker, an assistant, and they are teaching all the students to do a prayer. Here also one more Anganwadi. Once you come in the campus, we will take you to the Anganwadis, various Anganwadis you will be seeing, various children you will be seeing. You will examining all the points whether they are there in the Anganwadi or not. Then comes, as I have told you, that in growth chart they will be taking the weight. So the weighing machine which is seen in Anganwadis is not the weighing machine which we use in our households or in hospitals. It is a Salter's weighing machine. Why it is used? Because below 2 years of age the baby will not stand properly. So in this case, this is a sling type of weighing machine in which there is a bag and the child sits in this bag. See here you can see. So this is a sling and the child will be sitting in this bag, and in the dial we can see the weight. Then comes height measurement. Everyone knows the height measurement. So like this, see here the Anganwadi worker is measuring the height of the baby. Then comes mid-arm circumference. This is a Shakir's tape. This is used to measure the mid-arm circumference. If Shakir's tape is not present, we can use a normal Taylor's tape also. Why this is good? Because in layman also we can tell whether it is normal or not. Same like growth chart, there is green, yellow and red zone. If the baby's midarm circumference is in a green zone, means it is normal. If it is in yellow zone, that is mildly malnourished, and if it is in a red zone, then it is severely malnourished, and the patient has to be taken to the hospital and the calorific intake has to be increased. See here, the girls it is in coming in red zone, so we have to take care of such children. So this is your seniors last batch, that is 2019 batch, taken for Anganwadi visits. So this is Anganwadi of Loni and the children. Thank you. Sir, break आहे म्हणून सांगायचं होतं. Okay, fine. So you will be having a break till 11:30. Your next session will start at.
Good morning, guys. Today's topic is a field visit to a rural hospital, and I'll try my best to make you understand virtually what a rural hospital is about, what are the services, and how is it placed in the society, right? What are the services provided and how is it placed in the society? I'm Dr. Anand Bhide, and obviously it will be not that easy to understand and get an idea of what a rural hospital is, as easy it is when you actually visit the hospital. Obviously you will be visiting the hospital as soon as the situation gets better, but still this is a virtual introduction to the rural hospital. So we'll start with the topic. Rural hospital, or CHC, RH or CHC as they say, community health center. So this is a district level organogram. There is a civil surgeon, MHO or district health officer in a rural area. So we are in a rural area. So under district health officer there is taluka health officers, and under taluka health officers there are primary health centers. While as in urban area, civil surgeon is the head, under which there are district hospitals, then there are sub-district hospitals, then there is an RH or a community health center, which is 30-bedded hospital. A rural hospital or CHC is part of secondary healthcare system of Government of India. A population that a single RH covers cadres is 80,000 to 1,20,000. According to Health Standards 2017, 5,624 CHCs are functional in our country. It functions as referral centers for primary health centers. Structure. There are 7 different zones which provide facilities like X-ray, ECG, 1 operation theatre, a labor room and laboratory facilities. Zones are like entrance zone. Entrance has registration room, recording room, pharmacy cum store for Ayush, that is Ayurvedic, Unani, Siddhi and homeopathy. Then there is public utilities, and there is a free space for waiting area. Then there is an ambulatory zone, 4 general doctors room, 2 Ayush doctors rooms, 8 specialists rooms, treatment room, refractory room, nursing station, a casualty, dressing room, injection room, public utility area, waiting area and a cold chain room for vaccines. Then there is a diagnostic zone, path laboratory, storage for disinfectants, sample collection space, imaging room, preparation room and a toilet. Then there is an intermediate zone which has nursing station, 4 wards with 6 beds each, 2 male and 2 female, 4 private rooms, 2 male and 2 female, and 2 isolation rooms. Then there is a critical zone, that is operation theatre and labor room, para anesthesia and post-operative resting area, staff room, supplies area, labor room area, public utilities and free space. Then the sixth zone consists of mortuary, laundry, civil engineering section, mechanical engineering section, electrical engineering section, central sterile supply department CSSD and a dietary section. Then there is an administrative zone where the administrative officer executes his duties. What are functions of a rural hospital? This is the important question that somebody will ask you one day. Care of routine and emergency cases in surgery, care of routine and emergency cases in medicine, services related to maternal health, minimum 4 ANC checkups are necessary, 24-hour delivery facility, or referred cases, complications in pregnancy, labor and postnatal period must be adequately treated at a RH. Postnatal period of 0 to 3 days, the care is taken at RH. Essential and emergency obstetric care, newborn and child health, family planning services, all national health programs are executed at RH level. For example, revised National Tuberculosis Control Program, NVBCD-P, HIV/AIDS Control Program, NLEP, NPCB, that is National Program for Control of Blindness. Then there are school health services where camps are conducted for school children, regular checkup, diagnostic services of pathology, X-ray and ECG. A rural hospital acts as a reference center for PHC or subcenter because it has more facilities and qualified personnel. It's the part of district health system, so gets the benefits of exchange of services. It's the integral part of PHC and support activities of all PHCs and subcenters. Provides training to staff and makes them more professional and dynamic. What are the staffing pattern? There is a surgeon, then there is a physician, then there is an obstetrician, a pediatrician, anesthetist and ophthalmologist, then there is a program manager. Okay? Then the paramedical staff are a nurse, a dresser, pharmacist, ophthal assistant, war boy, safai karmachari, a chaukidar, a driver, statistical assistant, OT technician and a clerk and a radiographer. Okay? So population covered by CHC is about 1 lakh. Okay? Most of the clients that come to CHC are referred from PHC. Doctors available round the clock are medical officer, specialist in medicine officer, a surgeon, an obs gynecologist and a pediatrician. What are 24 hours available services? A blood storage facility, emergency surgical, it has contact with community, public health trained person, it is of FRU, first referral unit, and total staff of about 45. Then there is a dental surgeon available as per his timings. Now we will see the nearest rural health center, which is about 20 kilometers from here, where we will take you for the visit. Okay. This is the Gramin Rugnalaya Rahata or Rahata Rural Hospital. There is a rural hospital in Loni as well. This is a immunization center in the RH. This is where the vaccines are stored, a refrigerator, a computerized unit to enter the data. This is the ophthalmology department. They have written the time over there as well. Then there is this surgery unit. This is newborn stabilization center unit or NBSU, Navjat Shishu Sthirikaran Kaksha. And there is this dental OPD over there. Then there is this HIV TB center wherein they enter this data into these books. Data entry and maintenance of the records is very vital function of every medical officer. So there are these different registers wherein they enter the data of the patients. This is HIV positive pregnant woman register. This is for a register for a woman who register for people with HIV and TB. This is the requisition form. This is the daily patient entry and OPD register. This is our data, how they are calculated in the computer and computed and sent to higher center for reporting of the cases. If you have any doubts, you can contact me, and obviously once you are here and the situation is better, we will be visiting this center. Thank you. मी तुम्हाला मेसेज टाकला होता.
PPT सर्व कधी प्रेस करा.
Good morning students. I am very happy and excited to give a lecture. This is my first lecture to your batch, and it gives me so much of joy that I am happy to invite you to our college. Few of you might have seen me in the foundation or in your counseling sessions, and for the others it would be that we are meeting for the first time. So now starting, by this time you must be oriented to the different subjects what you have to study in your MBBS curriculum. So I am Dr. Sujata, and I will be taking a lecture on the sub-center and primary health center. Okay, so I am from Department of Community Medicine. So what do you actually understand by community medicine? Yes, it's when we speak of community medicine, it is more of prevention, and by this time you must have heard that prevention is better than cure. Okay, and here in community medicine, when we speak of prevention, we are speaking of prevention on a large scale in a community. And to emphasize the importance or to understand the meaning of this, I would just give you an example that you take yourself. So you would always want to prevent a disease for yourself, then taking a treatment. When it comes to tuberculosis, when a child is born, we usually give a BCG vaccine and try to prevent the disease rather than he getting the disease and then treating him for tuberculosis. So this is a very good example. Any few other things like we do maintain, we are wearing masks and all these to prevent a disease. So usually for all respiratory diseases, we usually use such techniques. For diarrheal diseases, we usually follow the hygienic practices. So this subject usually speaks of prevention on a larger scale. So with this introduction towards the subject, then we would move ahead to our topic for today. My topic for today is, I told you already, we are going to speak about sub-center and primary health center. So before I could directly start with sub-center and primary health center, it is important for us to understand that how is the what are the different levels of healthcare. Okay, so in levels of healthcare, we can divide them into primary, secondary and tertiary. So what I am going to deal with today is the primary, the grassroots level. So it's the place where people first go. Okay, it's the first contact of the community with the healthcare. Fine. So it is the sub-center and PHCs which form our primary health care. So I would just start with my presentation for today. So sub-center and primary health centers, I told you they are forming your primary level of health care. Okay. So first I would tell you about sub-center, and then after that we would go to primary health centers. Now about sub-center, there are 5 to 6 sub-centers under one PHC. Okay, so after this I'll just tell you what exactly PHC is, and it covers a population of 5,000 in plain areas and 3,000 in hilly and tribal areas. So as I already told you that it is the first point of contact between the healthcare system and the community. And mainly what you do in these sub-centers and primary health centers usually is the preventive and promotive aspect. Okay, lot of health education, health promotion, all those activities are very important component of these sub-centers. But they also provide along with this the basic level of curative care as well. Now important objectives of sub-center. So we have Indian public health standards which have been given to all these centers. So just before you had a class on RH or the community health centers, then for the sub-centers, primary health centers, for each of these you have specific guidelines being provided, and these guidelines usually, so before I could just continue with this, I'll just tell you what my objectives are for today's lecture. The objectives here would be that you should know what is a sub-center, what is a primary health center. For both you need to know the population that they cover. Other than this, important is the functions what they do, and then the staffing pattern what is there in both of these, that is the sub-center as well as the primary health center. So here the objectives for a sub-center specifically are that to specify the minimum assured services of these at these sub-centers, and what is being provided to what is being expected to provide, okay, and you should know even the desirable. The services are divided into essential and desirable services, okay. So essential, it has to be there, and desirable, it is good if it is there, okay. So the other thing is to maintain an acceptable quality of care for these services, and to facilitate monitoring and supervision of these facilities, and to make the services provided more accountable and responsive to people's needs, okay. So this is what the Indian Public Health Standard, okay, which is being mentioned for the sub-centers, okay. These are the objectives that has been mentioned. Now the sub-centers are divided into two groups, that is the type A and type B sub-centers. Now coming to the type A sub-centers, so you need to remember one important difference between these type A and type B is, in type B that there would be conduction of deliveries, okay. So that is the main difference between type A and type B. Not that in type A you cannot conduct deliveries. So the ANM who is there, she has to be trained even there, okay. But more of deliveries are being conducted in type B sub-center, okay. Type A sub-center will provide all the services except that of conducting deliveries, okay. However, the ANM has to be trained in midwifery, and she should know and she should conduct normal delivery in case of need, and if this requirement goes up, then this sub-center could be upgraded to type B. So the sub-centers in all these following situations which I am going to just tell you, they could be included in these categories, that is in the category or the type A1, fine. That is sub-centers not having adequate space and physical infrastructure to conduct delivery. So one important criteria is there is no enough space that is available in that sub-center. There is no building of their own, okay, and it's not spacious. So this is the first criteria. Then sub-centers situated in the vicinity of other higher health facilities like PHC, CHC, the first referral units, or any other hospital where deliveries are conducted. So if it's very close to that, then again there would be duplication of work, or there's no much need of this sub-center having this facility, because that's already being provided by these centers which are close by. Then sub-centers in headquarter areas. Then sub-centers where at present no delivery or occasional delivery is taking place. So all such sub-centers can be taken as type A sub-center. Now about type B, or you can even call it the MCH sub-center, okay. This would include the following types of sub-centers, that is centrally or better located sub-centers with good connectivity to the catchment area. Then they have good physical infrastructure, preferably with their own building, okay, and they have good space which is there, and labor room facilities, all that is there, then that could be taken as the type B sub-center. They already have good caseload of deliveries from the catchment area, and there is no nearby higher level of delivery facility. So all these could be taken as type B sub-centers. Okay. Now coming to the different or you can say the staffing pattern. I told you that you should know first what is a sub-center, and then the staffing patterns, and then the functions. Now in a sub-center, remember, this is a level of healthcare where there is no medical officer. Okay. So we have medical officer up to primary health center level. So in sub-center we have in type A, one health worker female, okay, and one health worker male, which is a essential criteria. And then we have staff nurse. It could be even that ANM could be there if the staff nurse is not available, and then the Safai Karmachari. Okay, in type A we don't, it's not an essential criteria to have a staff nurse, and Safai Karmachari also, it could be a part time. Okay, we could just depute the Safai Karmachari for part time. But in sub-center B, that is the type B, we should have 2 female health workers, 1 male health worker, and what I told you, the staff nurse, that has to, it is a desirable criteria for the B type of sub-centers. Okay, and the Safai Karmachari, because the load is there, the work is there, he has to be the full-time worker there. Okay, so this is about the sub-centers. Remember that here the sub-centers are run by the health worker, male and female. Okay, and in type B you should have 2 female health workers, and then the staff nurse, that is an extra, that is desirable in type B sub-center, and Safai Karmachari would be part-time in type A and full-time in type B. Okay, this is an important slide and you should remember this staffing pattern of a sub-center. Now coming to the functions or the services that are being provided in the sub-center. The first important service that is there is the MCH part, or the maternal and child health component. Now dividing them into maternal and child health. So you should know that in maternal you start from the antenatal part, okay, then the intranatal and the postnatal. So what these terms are: antenatal is when the lady is pregnant, intranatal during delivery, and then postnatal is after delivery. Okay, so the sub-center has to provide care during all these different phases or different periods. Fine. Now antenatal care, again I told you, most of the services or all of the services could be divided into essential and desirable. Okay, so it's essential, okay, that the registration of the pregnancies has to be done. So in sub-center, important, what they do is they target the early registration of pregnancy. Now what is early registration is at least before 12 weeks of pregnancy. Okay, and then the antenatal care, okay, that is a must, that is at least 4 ANCs, which will include the registration visit also. Okay, so when these visits are done is, I told you the 4 visits. The first one, it has to be before 12 weeks, okay, and then after that the second visit between 14 weeks to 26 weeks, and then the third visit 28 weeks to 34 weeks, and the fourth visit anywhere between 36 weeks and term. Okay, then the other important facilities or the services that are being provided is the child health. Okay, now what exactly is done in this child health is the immunization component, all that comes under this child health. Okay, so immunization is being conducted here, and again all these activities, whatever activities happen in sub-center, remember that it is in coordination. They work in coordination with the other workers or the health assistants which are there in the primary health centers. The Anganwadi workers are there, so the Asha workers are there. Together they plan all of these activities, if it is a celebration of any day, okay, or the health education part if they have to provide. So they work in coordination, all these workers which are there at this level, okay, at the village level, they work in coordination for the welfare of the community. Then they do work on family planning and contraception, okay, they create awareness about the different methods of family planning, okay. And if the health worker, the female health worker is trained to insert property, so even property insertion is done in certain sub centers, okay. Then counseling and appropriate referral for safe abortion services, so this is also a part of the sub centers. And other than that, some minor ailments are also being treated in sub centers, that is the curative services are also being provided at sub centers. Then about adolescent health care, it's again an important component of or important service that is being provided in a sub center, that is mainly the education part. So whatever doubts or whatever they queries they have, if they have any problems, so for all that education is being provided, counseling is being provided, and referral is being done, okay. Then assistance to school health services, so whatever school health services are there, which usually the primary health centers, the medical officer examines these children, regular school health checkups are there. So for all this, whatever assistance is needed is provided by the workers who are there here in the sub center. Then control of local endemic diseases, whatever diseases are endemic in that area, so they even help in the control of these diseases. Then they are even a part of disease surveillance, or which is under the IDSP, that is the Integrated Disease Surveillance Project. So what exactly this means is they need to be very alert when they are going to those places. So whatever they feel, okay. So if any disease in that particular time, if the number of cases are increasing, so they need to be very alert and immediately tell to the higher centers that there is this problem going on in their area, okay. So disease surveillance is an important service which is there. Then the water quality monitoring and sanitation, usually under this they even help, okay, they give education about the use of toilets and proper garbage disposal. So all this is being told by these health workers there. Then field services, outreach activities, they do go and conduct lot of activities outside also, like not just sitting in the sub center, they go out in the village and conduct these activities. Then the village health and nutrition day is also being observed, like here usually it is the education and the health promotion aspect which is being done. So these days are being usually they fix a certain time, and with the help of the other workers, that is the Asha worker, the Anganwadi worker, all together they come and they take a topic on that, they speak, they spread the knowledge, give health education and health promotion activities are being done. Home visits are done on a regular basis and data is being carried out. They keep a check if anything, any new diseases are coming up. So whatever is there, they go and just find out. If people are not coming to health centers, they even go from door to door, okay, like house to house surveys are also done. Now these home visits, they are actually very important when it comes to PNC, okay, the ANC sometimes, if the lady wants to plan her delivery at her home. So in this case, this helps a lot. So the health worker sees the place, is it actually suitable for the delivery, all that can be done in home visits, okay. And in the PNC, when she is going there, she examines the lady as well as the newborn, and she tries to see if everything is normal, or if the child, if the lady and the child needs help, okay. So if needed, then they will, or any minor ailments, they do treat there, or if needed, then they will advise them accordingly. Then coordination and monitoring, I told you there has to be coordination between all of these other workers also who are there at that level, and they have to work together. So certain national health programs are there, and the worker has to, she takes care of these programs. So mainly in all these programs, like few examples I can give you of national health programs is the program for AIDS, okay, national program for AIDS. Then we have for leprosy, we have for these different diseases, we have national programs. We have one for non-communicable diseases, for the vector-borne diseases. So all these, so vector-borne, I feel you'll know it slowly. Vectors are the insects which bite us and they causing disease. Very common example is malaria, dengue, chikungunya, so all these. So these national programs will be there, and what these workers have to do is, the most important component is the health education and health promotion aspect. Okay, they are making people aware of these diseases, what are their signs and symptoms, and how can you prevent these diseases. For some diseases, like example for the tuberculosis, sometimes like they are even the DOTS provider. DOTS is the part of the treatment where the patient has to take the tuberculosis treatment in front of any DOTS agent. So this health worker, male or female, can act as a provider of these services. Okay, so this is one. So in all of these health programs, mainly they do provide education and health promotion, and wherever required according to that disease, the specific activities are there. So they do take care of these activities. Then training of traditional birth attendants and ASHA. So another important component is this training activities also do take place. Then community need assessment is done by these workers here, and then see what are the needs of the community, and that will be told to the higher levels. Okay. Now a word about the job functions of this health worker male. So the health worker male will make a visit to each family once a fortnight. Okay, he will record his visit on the main entrance to the house according to the instructions of the, so they are clear cut instructions, so that will be followed by this health worker male. And his duties pertaining to different health programs which I just mentioned, he will carry out all these activities related to these programs in an integrated manner. Okay, so what is this integrated manner is, now he is not working separately. Now like before we had separate workers maybe for malaria also, but it's not like that. They are working integrated, that is they are working together for all these national health programs. Then responsibilities of a staff nurse, that all the RCH related, that is this MCH related or mother and child health or reproductive health. So about all these, the related activities will be included, and it will be done by a staff nurse. So from conducting deliveries, episiotomy, so especially in the type B sub-center, so all that will be taken care. Supervision and facilitation of immunization work, supportive supervision and facilitation of all the work to be done by health worker, female and male. Okay. Then training of these subordinate staff, and running the sub-center OPD, and ensuring that the quality, like overall the quality in delivery of all these services is appropriate. Okay. In short about the kits that are available in these sub-centers. So there is type A and type B kit. So type A is for this which will be there in the type A sub-centers usually. So here we have ORS sachets, okay, around 300 packets will be given. Then iron and folic, we have small tablets, large tablets, and iron and folic acid syrup also. So syrup 400 bottles, and the small tablets provided would be 13,000, and the large would be 15,000 tablets would be given. Other than that, separately folic acid would be given, that is 1500 tablets. Then so all these are for anemia. Okay, iron and folic acid what you get, it's to treat anemia. Fine. Then we have Septran tablets, around 1000 tablets, that is usually the pediatric tablet which would be available. Septran is an antibiotic that has been available in these sub-center. Okay. Then we have this junction violet crystals, that is 250 gram. Junction violet could be used maybe for oral candidiasis and all in a newborn if they have this oral thrush. So that time this purple colored liquid, actually first it was even used to paint the nails in pulse polio program. Other than this, junction violet could be used on the umbilical cord if any secretions there or something, so it acts as an antibiotic. So that is available there. Other than this, you have vitamin A syrup. Okay. Then in these other than this, you have for the type B subcenters. So you know that deliveries are being conducted. So we have methyl ergometrin tablets and injection which is available. Tablets 240 tablets and 10 ampules. Okay, injection will be there. Then paracetamol also will be there in this kit B for type B subcenters. Okay, so this is available in these subcenters. Okay. Word about the records which they need to maintain, which is a very important component. So whatever they do, it has to be there in these records or registers which are there. Okay. So the registers which are maintained are the eligible couple registers, including all the contraception so everything about the eligible couple and the contraception what they using. Okay, if they are using. Then maternal health registers, the ANC I told you, antenatal, intranatal and postnatal registers. Under 5 registers are maintained. The family survey registers are maintained and the adolescent girls register is also maintained. So this is all about subcenter. That is first it's for a population of 5000, around 5 to 6, usually 6 subcenters under PHCs. Okay. Then the staffing pattern, you should know that there is no medical officer in a subcenter. Okay. You have health worker male and female, and other than that one each. Okay, in type A, and in type B you have 2 health worker female and 1 health worker male. Okay, and staff nurse, it is desirable to have it in type B, and Safai Karmachari is part time in type A and full time in type B. Fine. Okay. So with this and the activities you are well versed. Fine. MCH, child health, then home visits, then surveys which should be conducted on a regular basis, national health program. So this was a short summary of the sub-center. Okay. Now moving on to the primary health center. Okay. So first in 1946 the Boer committee said that we should have these primary health centers as a basic health unit. Okay, which would be very close to people, and the services that are being provided here, they should be integrated. They should have curative, preventive, so all this has to be there in these primary health centers, and they should provide this. And another important thing here now, the latest according to the latest data, that is the March 2017 data, around 25,650 PHCs are present, okay, in India, and about the number of sub-centers, just multiply it into 6. Fine. So that are the number of sub-centers that are present. Okay. And now regarding the population that is being covered, it is 30,000. Okay, just remember this number, that it is 30,000, and in the hilly areas and all it is 20,000. Okay, and it acts as a referral for 6 sub-centers. Fine. And whatever cases here need to be referred, then we could refer it to the higher center, that is the community health centers or RH, what you just seen. Okay, you just had that lecture. Fine. And so this is the most important. Earlier what was thought in the previous, like Boer committee, they felt that it should cover a population of around 80,000 to 1 lakh. Fine. but slowly they felt it was difficult for these PHCs to cover and it was not possible. Then they came down to 40,000, and then now the latest one, so what we tell now or we teach now is they should cover a population of 30,000 and then 20,000 in case of hilly areas. Okay. Fine. Now objectives for primary health centers are to provide comprehensive primary health care to the community through these primary health centers. Now what does this word comprehensive mean is, in total they need to provide all the services from promotion, prevention, okay, to curative and rehabilitative. So all this has to be there. So that is comprehensive. So total health care has to be provided to the community. To achieve and maintain an acceptable standard of quality of care, to make the services more responsive and sensitive to the needs of the community. So this has to be done. Now next is the functions of primary health care. Okay. Now in functions of primary health care, you should know that it is mainly the medical care, the MCH services, safe water and sanitation, prevention and control of locally endemic diseases, education about different health. Okay, overall you can say this is health education, collection and reporting of vital statistics, national health programs, referral services, training and basic laboratory services. So how do you remember that all these services are being conducted in a primary health center? So just imagine a lady having nausea, she goes to a doctor. Okay, so as soon as she goes to a doctor, so what the doctor does, he asks her to relax and sit, gives her a glass of water and he gives her PPE. Just remember this PPE. So we'll just see what this is. Okay, once I finish off with this. So when he gives that, then after that he says that congratulations that she is pregnant and it is a ANC case. With time she delivers a baby. Then when the baby comes, he just congratulates her and gives her a certificate. Okay, so what this certificate is, we'll see. Fine. And then once the child is growing, he asks him to go to a pediatrician. And once the pediatrician, he goes to a pediatrician, the pediatrician says your means everything is fine and now you can go for your training. Okay. Before this, what I just missed was, when the lady comes to a doctor, he examines her. Okay, he does a blood examination, then gives her a glass of water and then he gives her a PPE. Now we will just see this one by one. So how we could remember these? So when the lady is not well, she has nausea and all that, she goes to a doctor and he gives her medical care. Fine. And then he says that congratulations, you're pregnant. That is MCH. He provides the MCH services. Fine. Then he gives her a glass of water, that is safe water and sanitation. He gives her a clean glass of water. So you can remember this, safe water and sanitation. Then I told you PPE. Now what is this PPE? You can remember P. One P is for prevention and control of locally endemic diseases, and then one P is for national health programs, and E is for education about health or health education. Fine. So he is giving her water and giving her PPE and he is getting her blood test done. Okay, that is the basic laboratory services which are being done. Okay, or it's a function of a primary health center. Now other than this, I told you, then he congratulates her, a baby is born and he gives her a certificate. So this is a birth certificate. So birth certificates and all these are part of the vital statistics. Fine. So you can remember here, that is collection and reporting of vital statistics. Then what I told you, once the child is born, refers the child to his friend, that is a pediatrician. So referral services, very, very important. What cannot be handled in the primary health center has to be referred. Okay. And then the pediatrician says, you're all fine, you're all good, and now you can go to school for your training. So important function of primary health center is training activities happen. So what is the training that happens here is the ASHA workers, the training of these dyes, okay, and the other all similar kind of training of these health workers happens here in the primary health center. Okay, so you with this it will be easy for you to remember what are the functions of primary health center. Next, about the different types of primary health center, we have two types, that is type A primary health center and type B. For this you can just remember, so wherever this type B and type A and type B are there, you should remember it is related with deliveries. So in sub-center we said that in type B deliveries are being conducted, and here in primary health center in the type B the delivery which are conducted are 20 or more than 20. So you can just remember that 20-20 cricket, so you will remember this value of 20. So in type B it is that more than 20 deliveries are being conducted. Okay. Now about the staffing pattern, just remember in total in type A you have 13, which is essential criteria, and in type B you have 14. Okay. So important, I told you from PHC you have a medical officer. So you have one medical officer each in type A and type B. Okay. And this is essential, and this medical officer has to be a MBBS graduate. Then it is desirable to have a Ayush medical officer. Now Ayush are the other systems of medicine like the Ayurveda, okay, then you have Unani, Siddha, homeopathy. So all these together it forms the Ayush. So it is desirable to have one second medical officer, you can say one medical officer of Ayush, okay. Then in this health center you should, anywhere for data entry you should have a accountant or a data entry operator. Then you have a pharmacist, okay, to provide the medicines, okay. Wherever there is OPD, wherever there is medicine, there has to be a pharmacist to provide it. Then you should have, okay, it is desirable to have a Ayush pharmacist also. Then about staff nurse, you need to have essential, it is 3 in type A and 4 in type B, okay. Then health worker female has to be there, 1 each, okay. Then we have health assistants male and female. Then health educator, which is a desirable one, it is good to have a health educator. Then lab technician, again it is essential to have one lab technician, okay, in both type A and type B. Then other than this, you should have a cold chain and vaccine logistic assistant. For this is again desirable, it's good if they have, okay. Then multi-skilled group D workers have to be there, so 2 each, okay, in type in type A also it is 2, and in type B also it is essential to have these 2 multi-skilled group D workers. Then sanitary worker come watchman, okay. So 1 in type A and 1 in type B. So I told you totally 13 staff in type A and 14 in type B. So about the services at primary health center, similar thing, medical care, MCH, family planning services, MTP, health education, nutritional services, school health services, adolescent health care, so disease surveillance and control of epidemics. So very similar to what we had in sub-centers, but a lot many are much more here in primary health center. Then we have collection and reporting of vital events which have to be done. Then promotion of sanitation, which is important, testing of water quality and disinfection of water sources. Again similarly what I told you in the sub-centers, all these national health programs, and they need to work. So each national health program will separately have certain essential duties and desirable duties, okay. Appropriate and prompt referral of cases needing special care and provision of transport facilities also has to be done by these PHCs. Then record of vital events, that is reporting of births, deaths and maintenance of all sorts of vital records is the duty of this primary health centers. Training of all health workers, okay. So it is the traditional birth assistants which are there, so training them, fine. Or you can say once these are trained, okay, the birth assistants, so they know the important ways of how to conduct deliveries, because in rural areas still there are few who would want to get their deliveries being conducted at their homes. Then the ashas, the paramedics, then periodic training of doctors, ANMs, the health workers, okay, the lady health worker and all those, fine. Then training under IMNCI is also being provided there. Then training of pharmacists on this important Ayush component, training of Ayush doctors. So all these different types of training happen in primary health centers. Then the lab services. So all important ones I just told you in the functions of PHC. Okay. Then we have monitoring and supervision of sub-center activities, that is all national health programs, activities that have to be done by ASHA. So all that is being monitored and supervised. Then selected surgical procedures like vasectomy, tubectomy, then MTPs, hydrocelectomy and cataract, all this will happen in a primary health center. Then mainstreaming of Ayush is also done. Okay. In short, about the job responsibility of a medical officer and other staff at these PHCs. So a medical officer, he is a captain of this health team. So usually morning hours he is seeing patients, okay. Then afternoon he supervises the field work. He covers all basic services including family planning. He will plan and implement the immunization programs as per the guidelines. He ensures proper implementation of IMNCI as per guidelines. So IMNCI, in your further classes you will see that it's nothing but the long form of this is integrated management of neonatal and childhood illnesses. So in an integrated manner, all the childhood illnesses which are there would be treated, and there are specific guidelines under these. Then he visits to school in PHC area and he arranges for a medical checkup and immunization. So school health activities are also done. Organizes and conducts tubectomy and vasectomy camps. Organizes training of all health personnel, ASHA, Anganwadi worker, DAIs, etc. Ensures proper implementation of these programs, national health programs. Regular visit to sub-center and provides guidance, supervision and leadership, okay, to the full team of his, okay. Organizes staff meetings at PHC, that is once a month, to discuss the problems and review progress of these activities. Medical officer must be a planner, promoter. So these are the important qualities what he should have. He should be a planner, promoter, director, supervisor and a coordinator, as well as an evaluator, which is very important. Okay. So evaluation of what is being done is an important component. Okay. So I'll just show you one or two pictures of these primary health centers, as we are telling you that if once you come back and situations are good, you would have these visits. Okay. So this is a photo of the primary health center. So this is the cabin of a medical officer. Okay, and you have separate wards there. Other than this, you have the pharmacy unit. You have the important is the separate wards you have for males and females in a primary health center. Okay, and here it's an image there from a primary health center only. That one is directing that there is a room, that is the OT which is there. Okay, and then Hirkani Kaksha is usually this is used for the breastfeeding part. Okay, they have a separate room which gives facility for the mother where she can breastfeed her newborn, okay, or a child. Right? Thank you.
आता कोणाच नाही ना